All right, guys. Hopefully everybody can hear me. I want to make sure we have time to get through the slides. Crossing fingers, this is my second attempt at doing this presentation, so hopefully no technical difficulties will occur this time. So today the talk is going to be on smart therapy for treating asthma. And for you, like those of you that don't know me, I'm Amy Barker. I am the nurse practitioner in pediatric pulmonology for Carilion Children's. And there we go. So the objectives today are listed there. Really, it's just kind of presenting what the SMART guidelines are, specifically for treating children with asthma. Hopefully be able to identify those candidates at the end of this talk that might benefit from it. And then discuss some barriers to the implementation. And of course, I have no disclosures to share with you. So just for time's sake, this presentation is going to assume that the listener is somewhat familiar with the initial guidelines for asthma released in 2007, or the expert panel 3, also sometimes it's referred to. And then the next 2 slides I included simply for your reference, just in case. This is specifically talking about the classification of the severity of asthma, which of course is important in figuring out treatment, and then also assessing the controls, so that's what we're going to be doing once we've initiated that treatment. So I just included those 2 for you guys to be able to refer back to if needed. This is the wonderful alphabet soup that you guys might be familiar with when it comes to asthma management. So there's a lot of acronyms, and so I just put those in there for your reference as well. So let's get started. So what is SMART? SMART is somewhat of a game changer, huge change in thought process when it comes to treating asthma. So it stands for the single maintenance and reliever therapy. So you're using this one inhaler, not only for controller therapy, but also that rescue. So that whole verbiage that we use with our patients saying that rescue is for rescue, you don't use it for prevention, no longer applies to this group of patients. So this is the guideline. So this is the update, the EPR4. This is released in 2020. The patient population we'll be focusing on today for this discussion will be those children that are 4 and older with moderate to severe persistent asthma. Listed here are the updated recommendations. And so this is contrast to the previous recommendations that we have been going by since released in 2007. So who should you be considering SMART for? So the target population for our kiddos are going to be, like I said, 4 years and older with the moderate to severe persistent asthma. And then the severe exacerbation in the last year. And so that's going to be defined as an ER hospital, or like an ER visit, hospitalization, or systemic steroid burst for 3 days or more in the last year. And then those that are uncontrolled on the ICS-LABA with a PRN SABA. So that's really who we would be focusing on. So you're looking at step 3 for low dose, and then step 4 for medium dose ICS-LABA, just to kind of put that in there for you to think about. So who shouldn't be receiving this? So this treatment is based on ICS salmeterol. And so that particular one has a quicker onset of action. So what that means is that's why it's able to be used as a reliever. Those that are on the alternative, like Advair, so particularly these are those individuals you have on Advair right now that possibly are not controlled. You should not be adding Symbicort to their therapy as a reliever. So lots of people may have questions if poor perceivers would be good candidates for SMART therapy. So poor perceivers are going to be those patients that typically do not recognize their breathing difficulties and when they might need their rescue medicine, their albuterol. So these patients have a very strong association, and you probably can think of a couple of patients within your practice that have poor adherence to their daily controller medication. So they may have been prescribed Symbicort or Dulera, but they are the ones that come in, they're using it, 5 to 7 times out of the 14 times a week they should be. And of course, this is going to result in greater visits to urgent care and near fatal asthma. So those poor outcomes that we're trying to prevent, right? So what is really great with this therapy is actually SMART therapy had decreased days without ICS LABA. So those days possibly where those kiddos were using their albuterol as a rescue, instead of taking their preventative, now they're grabbing their preventative reliever. And so they're getting that added benefit of having the ICS LABA on board more. And this has actually been very helpful in decreasing those bad outcomes. And it also increases their overall exposure to having the benefit of the ICS too on board. So what about a patient that's well controlled on what will probably it's called the alternative on the new guidelines, the 2020 release. This is what I would say is the alternative on the recent or the current guidelines, but was the preferred before. So that ICS LABA with the SABA PRN. So if you've got a kiddo out there that's well controlled on this therapy, even if they're on step 3 or 4, there is no reason to change them. So don't break what's working or whatever the saying is, that they can stay right where they're at. So if it's not broken, don't fix it. So let's talk about the dosing of what SMART therapy looks like. So SMART therapy is going to be the ICS formoterol, should be administered as their maintenance dose is 1 to 2 puffs once to twice daily. Now this is all depending on the age, the asthma severity. And so I think it's important to point out here that at this time, there really is not a well-defined starting dose and the age group. So in regards to the number of puffs and frequency, so again, daily versus BID, and then is it 1 puff or 2 puffs? So the biggest thing to know is that they should not be going over, for their age, their max number of puffs per day. And there is some discussion throughout some of the more recent reviews of these guidelines of 1 puff or 2 puffs. 1 puff, they say use 1 puff to start out with, and then if they need more than that, when they come back, if they're not controlled as their maintenance dose, right, then increase to their 2 puffs twice a day. And then also starting with 2 puffs twice a day, or 2 puffs as a reliever could actually escalate their formoterol dosing quicker than it actually needs to be. So next, I want to just kind of go over some guidelines that other children's hospitals have in regards to what dosing they use in their facility or in their institutions from a SMART guideline. So this one in particular, this is looking at the differences between Symbicort and Dulera. I do want to point out that it is the SMART therapy, the research was based on Symbicort specifically. Dulera is included because it is another option with the formoterol that we discussed that has that quick onset LABA in it. And so there was not any study done in particular with Dulera, but because there's insurance issues, availability, all of that, institutions are consistently using both as options for SMART therapy. Again, Advair is not to be used as SMART therapy. So this just kind of looks at the medium dose, okay, and the low dose. So if you recall, I said the low dose column would be particularly for step 3 of asthma treatment, and then the medium dosing should be step 4. Again, the max dose puffs is what's really important. So anywhere from them taking 2 to 4 puffs on a regular basis as preventative, then they have that many extra puffs to use as rescue. And it's pretty easy to remember. If you're 12 and over, your max is 12. And if you're less than 12, it's 8 puffs total for the day. So this is just one more example, and what I'm just trying to point out again is there's just not really consistent idea of to start with 1 puff, 2 puffs twice a day or daily. This is really in particular for just their maintenance dosing. This has nothing to have any bearing on their rescue dosing with their ICS LABA. And then also I just pointed out the differences with the 12-year-old to the 4-year-old. These institutions that I found these guidelines for are hospitals like Minnesota's Children's, Nationwide Children's. So they're larger facilities that actually have this as their guidelines in the hospital and outside the hospital for asthma management. So once again, that just kind of breaks down and points out the step 3 that I was talking about, and step 4 with the moderate persistent. And this is particularly for Symbicort. So successful prescribing, you can imagine that some of the biggest barrier to implementing this type of change of treatment in our children with asthma is actually being able to provide enough of the inhalers for the treatment. So lots of times your 1 inhaler is not going to provide enough to be both a reliever and also their maintenance dosing. So this is just for you guys to reference back to. It's important to, just like some of you might do for when the previous kind of traditional use of albuterol as a rescue. Oftentimes I'll put in the comments 2, dispense 2, 1 for home and 1 for school. Again, I just make sure you put in 2 inhalers and note that it's for a 30-day supply. The other thing that you can do too is like Symbicort. I don't know if you guys have noticed when you do, or if you do order that, it is not a 30-day supply. So they can actually pick that Symbicort up before the 30-day mark. So I encourage them to do that. So even if they don't need it, so that they can stock up on some extra and they have it if they do need it. So the biggest thing, what does sick dosing look like with SMART therapy, right? So for the sick plan for our patients, we're going to want them to take 1 to 2 puffs, again, of the Symbicort or the Dulera that they're on, and that'll be every 4 hours. So this looks very similar to how they would use their albuterol, right? And then just in referring to, you know, our stoplight for our asthma action plan, you can see if they're in the red zone, they're going to do that 1 to 2 puffs every 15 minutes. And again, keeping in mind that there is a max for the age. So less than 12, it's the 8 puffs total, and 12 and up, it's 12 puffs total for the day. So this takes a lot of education, spending time. It's a huge change in thinking, not only for the provider, but for the family, and sometimes can cause some anxiety. So really working with them and making sure that they understand how to implement this and what the benefits are. But what you need to do is tell them increasing therapy. So if they're having to exceeding daily puffs consistently, or if they're needing even just their max puffs for greater than 2 to 3 days, then they probably need to have possibly need an oral steroid burst first. So to contact you guys and discuss how that's going and what the next step is. And again, that this is just key to tell the families, don't jump straight to using albuterol, nebulize or MDI when you have problems breathing, that they need to use the Dulera or the Symbicort just like they would have their albuterol. I think that sometimes what I've been doing with that first month or so is they still have albuterol available, but I tell them, please don't use it. Use what we discussed. And if you feel like you've run out of your puffs and you're going to use that albuterol, so your max puffs for the day, to please contact me so we can discuss that more and figure out if we need to adjust therapy. So of course, how does our asthma action plan that we all have to have, not only for the parents to reference, but also the school, right? So that they know how to use this as well. So there is not really a good one out there at this point that's specific for pediatric patients. The best one that I could find was from Allergy and Asthma. And again, they did try to use this as just like we would our other one, and kind of a red, yellow, green, or green, yellow, red zone. But really taking the time to walk through this, again, the green zone is no symptoms whatsoever. It definitely talks about this is what you take on a regular basis. This is how you're going to use your reliever. And then as they step up with their symptoms, how to step up in taking this. So what are some potential benefits and risks with the SMART therapy? So actually, it has been shown to reduce the asthma exacerbations. That includes use of not just systemic steroids, but there's urgent care or ED or more time-consuming PCP visits that they need oral steroids with, or just breathing treatments with. So it also has been shown to improve the asthma control and quality of life. So why do we treat asthma? One of the big things I always tell my families, of course, is asthma control is important. So, but we don't just treat the numbers, we treat symptoms, and quality of life is a big one. So helping those parents not to be so scared that they're going to have a severe exacerbation, that the kiddos don't have to feel restricted with their activity. That should be a huge red flag, because playing and being active is a kid's job. And it's good for, not just the body, but also the mind. In children age 4 to 11, there actually might be a little lower risk of growth suppression among those taking SMART versus the high dose ICS treatment. So that is a huge benefit, because parents are very concerned about how that's going to affect their kids' growth, how it'll affect their immune systems, those types of things. And then simplified regimen and just single medication. I don't know how much time, I would assume a lot of your time with your asthma patients, you guys are spending educating. This is a reliever, this is how you use it, and this is your maintenance. And just going over and over and over. I have made so many different charts, references, discussions, just trying to get my families to understand when and how to use their medication. And it can take multiple visits, and sometimes I feel like it never is going to happen. So I think that this one inhaler where they can use it as a rescue or as and as a maintenance is huge, not for just them, but also us. So I think that is a huge benefit. And of course, the increased adherence, as I referenced before, with having increased ICS, even in those poor perceivers. And then the lower total ICS dose. So in about 6 to 7 multidisciplinary, multi-centered studies that were reviewed, it showed that use of the ICS LABA, like as a rescue, so not well controlled, like as a rescue, they had less than 50% as a rescue compared to the ones that are on the ICS LABA with the SABA. So in other words, overall, they felt more controlled in using this and didn't feel like they needed to reach for a rescue med. Potential risks. So there really is no difference between the SMART and the daily ICS or ICS LABA. So, but again, it is difficult for parents to switch that mindset when we've spent so much time kind of beating it into their heads that this is how we need to treat, and why do we not use our controller medication as a rescue? I've said it a million times. It does not have that quick onset. It's not a rescue. It's not going to make you feel better. So really just working on education and discussing these benefits is going to help that mind change. So barriers, right? Barriers to the SMART therapy, barriers to any change, right? I think I saw a reference where it takes almost 17 years to really implement true change in an institution, which is crazy to me. But so there are definitely barriers, and we've talked about some of them. But the medication side of it, so there's the lack of understanding of SMART. So if you have educated them, they come back and they still do not understand how to implement this, they're using albuterol on top of everything, then we might need to consider going to the alternative treatment, or what I would label the traditional pathway, which is per the 2003 guidelines. A big thing, of course, is improper inhaler technique. That's a barrier to any therapy within asthma. Knowing that how they're administering it, making sure that every individual has a spacer, because it doesn't matter how old you are or how good you are at using it, you have to have the spacer to get the full benefit with an MDI. And then really understanding the action plan is going to really need to be focused on for those individual families, for them to be successful in implementing this. We've talked about unable to access medications from not only an insurance, but also pharmacy issues. I'm sure you guys have heard that with a lot of different medicines, back orders, you need a prior authorization, which these most likely are all going to need prior authorizations. And then the last would be what I just referenced, unable to obtain or lack of use of spacer. And I definitely see that way more in our middle school and high school kids that self-carry, and they just don't want that big clunky thing, and they don't want people staring at them. So really working with them to realize why. So how does it institutionally, what is the barriers? So provider, right? It's a huge shift in our thinking. And then continuity within the system. So if you can imagine, if they're seeing us and we implement SMART therapy and they call the PCP or and say, I am not doing well, this is how I'm using it, and we're not familiar with the SMART therapy and what to do next, can imagine a provider then saying, well, start your albuterol and let's do this, this, and this. So really being more familiar with what the guidelines are and how to implement them within your setting is really important. Also, the school nurses. So in the area, the school nurses may not be familiar with this update. It is a lot easier to implement this in the self-carry age range, which is the middle school to high schoolers, right? So because you don't have to have one of the inhalers within the clinic. So when I write dispense 2, one can stay with the child, and then they have an extra one at home instead of having one in the clinic. But really working with the school nurses to understand how to implement this is important as well. Insurance coverage, of course, we talked about needing to dispense more than one a month and working with those prior authorizations, so those patients don't go with gaps in their maintenance therapy. When SMART fails, so what do? So there, of course, the ensuring, just like any therapy with asthma, the proper technique and ensuring that the medication is being delivered. And then also ensuring that the family understands what SMART therapy is and how to use their ICS LABA as a rescue. And then the other thing is we can go from 1 puff twice a day to 2 puffs twice a day as a maintenance. So that's an option as well. But if that still continues to fail, referring to us, the pulmonologist, or an allergist, because at that point they're going up to probably step 5, 4 or 5, and at that point they may need consideration for a biologic and daily oral steroids and the high dose ICS. So what does this look like? So if we have a kiddo that is on Flovent 44, 2 puffs twice a day, and that's they're still having lots of exacerbations, even coughing at night, then from step 2, we want to go to step 3. So the traditional pathway would say to go ahead and start a medium dose ICS LABA and continue to use your SABA, so your albuterol. So the SMART pathway for the same patient for step 3 says that we should use the LABA ICS, and that can be 1 to 2 puffs twice a day or daily, and then to use their 1 to 2 puffs PRN as needed, remembering what that max dose is per age. And then just kind of that, I'm sorry, that one was out. That should have been in front of the other one. And so those are my references. And that is actually it. Does anybody have any questions? Okay, so if anybody has any questions or further comments, then you want to get in touch with me, you can, and I appreciate your time, guys.
It looks like there's one in the chat.
Oh, is there?
Mm-hmm.
Oh, I see it. Remember when you mentioned 4%? That's a good question. Okay, so it's, I'm not sure if everybody can see it. It says, you mentioned poor perceivers. Any data about over perceivers that exceed puffs per day treating a cough? And then do these MDIs have a built-in counter? So both good questions. So actually, no, I did not see anything in over perceivers. And I didn't even really contemplate that, but that makes sense. So I'll have to say no, and if I find anything, I'll let you know. But that's a good point. So again, I think really that is getting down to what's the cough coming from, discussing when to use it. Typically, I tend to see my patients use their relievers a little bit more when they have some underlying anxiety or vocal cord dysfunction. So really getting at the crux of what's making them use it might be helpful in addressing that. As for the counters, yes, they all have counters on the back. So they will tell you exactly how many puffs are in there. And then I usually try and get my families to bring their inhalers, their MDIs, to their visit so I can check how they are using them, administration to make sure if there's any issues, and then also you can go over how many puffs they've used in that month. Anything else? Okay, guys. Thanks so much. I appreciate it.
Thank you, Amy.
Mm-hmm.